function gets deteriorated and patient suffers from some illness. Chronic liver disease are the condition where liver gets structurally damaged because of some conditions, and there is a condition called acute and chronic liver failure where there is a pre-existing chronic liver disease, but the liver function gets acutely deteriorated because of certain issues. They donated to their son, to their children, so all of them went home. And in one of the pictures, there is one gentleman who is a position.
When you say that there is a 92 to 95% chance of success, that means that this is a surgery where there is a 5% risk of mortality also. But a 5% mortality is for a patient who otherwise would have a 100% mortality. You understand? This is a disease which has no treatment. End-stage liver disease has no medical treatment. You can only stabilize the patient and optimize them till they get a transplant. So all these patients, as I said before, would otherwise die. But now because of transplant, 90 to 95% of them are living and they do well. And because the liver is a regenerative organ, they continue to live for long periods of time. Okay. Now, complications could be related to the surgery per se. Most likely these are infections because you immunosuppress these patients after the transplant because it's an organ from another person. So when you decrease the immunity of a patient, infections become the number one cause of complications in these patients. Technical complications in terms of the blood vessels that we join, them getting blocked or them having some bleeding is to a minor percentage, maybe 2 or 3% of the time. But overall, these complications are probably amongst the major ones that you look at in post-transplant patients. Regarding ICU complications?
In the ICU, usually as Dr. Gulprasad has said, that transplantation is a very complex procedure. It's not an easy thing. That is why it is not been done in the most of the centers. You need a kind of license for having a transplant done in any center. So why it is complex? Because in the post-transplant period, we often see a lot of systemic problems, like their blood pressures might fluctuate for a couple of days, the bleeding might happen for a couple of days. Those things need to be monitored, treated. They might require artificial bleeding support, ventilator support for a few more days. So those things need to be managed based in an intensive care unit. The idea of having a robust intensive care unit support is to give each and every organ the adequate support which it requires and which might become stabilized after a few days of time as soon as the liver starts working on its own. So that is our sole idea of having a robust ICU support.
Discussion है mostly liver transplant. Today's occasion mostly is to talk about liver ICU. जो हम ज़्यादा prevention और समझो जिसको liver associated disease है patient को उनको हम जल्दी से ICU में लाके उनका जितना treatment transplant is slightly later part. So, but for us today's aim was more to make awareness towards the liver ICU. So whoever patients or whoever referring hospitals who require that kind of expertise, they are launching for that. So I'm just bringing the progress.
This is Sachin from Rural Families. I'd like to know, firstly, congratulations for opening this dedicated ICU unit for liver. So I just wanted to know patients who is having other ailments, like having heart ailment or any kidney ailment. So he approaches for the dedicated liver ICU. So does the ICU cater to his other needs?
Suppose now the same question what she asked, what is the ICU? Basically, our patient when he comes to the hospital, it's possible that he comes only for the heart. It's possible that he comes with the kidney, and then subsequently after 2 days you realize that in addition to the heart and kidney, he has a liver problem. So now to answer your question, primarily when patient comes to ICU, primarily we assess the patient, we make a provisional diagnosis. At that point of time, it's possible that he had hypertension, kidney, heart, brain. So that point of time, what we see, what is the topmost priority for which the patient comes to the hospital. And suppose we feel that point of time that yes, he had a cardiac issue, so he goes to the cardiac ICU. That point of time, suppose we know that primary looks like there is a liver issue, he goes to the liver. So the idea of liver ICU is that the liver doctor might come and say, just give an example, that this gentleman requires a lot of water. But again the cardiologist comes and he says, no, his heart is very weak because he has angioplasty, he requires less water. So our job is to just fine tune everything, and do whatever the best appropriate care at that point of time, which is the topmost priority at that moment. So coming to your answer, yes, it's possible that the patient comes with the liver and he has a cardiac issue and all that. So we are in the situation to handle that. But that point of time, as the problem is started with the liver, he or she goes to the liver ICU.
I will just expand this a little more. Most hospitals will have a ICU, well-equipped ICU and all. What we are talking about here is a dedicated ICU for liver diseases, not only for transplant. Most centers which are doing transplant will have a transplant ICU, limited number of it. Here we are talking about, and it's always a multidisciplinary approach, like what Dr. Akshay just mentioned. So whatever ailments patient is having, it's a multidisciplinary. Patient has a cardiac issue, the cardiology is also part of the team. But the point here is that the liver ICU by a dedicated liver hepatologist and intensive care specialist, and rest of the staff is also trained to look after the liver patient. So it's dedicated staff which is only looking after the liver patient. Any additional ailment will always be supplemented by the respective teams.
There are many tests that are available to help us identify a patient who is having a severity of the liver disease. We have something called as a brain score. That score tells us about how bad the liver disease is, and there are multiple factors that dictate what the brain score would be. For example, INR. INR is a value that tells us how bad the liver dysfunction is. The liver INR government prothrombin as a घटक बनवतो, it makes prothrombin. And what we measure is prothrombin time when we look at the INR. At the same time, the synthetic function of the liver is also. So it is albumin level, the serum albumin level that helps us to identify how sicker the patient is. At the same time, the other parameters like bilirubin, other parameters like encephalopathy, JCPT score will ascites in the abdomen. There are various parameters. So this is not a single parameter, but a composite score of multiple parameters that help us to decide and stratify if this patient is having a mild, a moderate, or severe disease.
Yeah.
What is the percent of failure in matching the?
So fortunately, the liver that way is a very friendly organ. It grows and it comes back to the original size, and it also doesn't require that kind of matching we require for a kidney transplant. So just a blood group that is compatible to the blood group of the patient can be a donor, provided they are related in the family, or if you're getting a cadaveric organ, then we need the same blood group. So why we need the same blood group in cadavers? Because cadaver organs itself is a scarce resource. So only those patients' organs which match with your blood group are given to you. But when it's a family donor, any blood group that is suitable to the blood group of the patient, you can give the organ.
प्रॉब्लेम्स मधून जातो आणि जे प्रॉब्लेम्स असतात म्हणजेच लिव्हरमुळे मेंदूवर तणाव पडतो, लिव्हरमुळे फेफसांवर तणाव पडतो, किडनीवर तणाव पडतो, याला इंटेन्सिव्ह केअरची गरज पडते. हे आपण घरी ऑन ओपीडी बेसिस सॉल्व्ह नाही करू शकत. सो फॉर दॅट आयडिया ऑफ giving them the best care before the transplant and obviously after the transplant, and that is where the liver ICU comes into picture.
सच आजार त्याच्यामध्ये कॉम्प्लेक्सिटी खूप जास्त असते. बऱ्याच वेळा पेशंट वेळेवर आपल्याकडे पोहोचतो किंवा नाही, त्यांचं पहिली ट्रीटमेंट झाली आहे किंवा नाही, खूप मोठे मोठे फॅक्टर्स असतात. ह्याच्यामध्ये दोन पद्धतीचे असतात, जसे सगळी लोक म्हणतात. अल्कोहोलिक लिव्हर सिरोसिस किंवा लिव्हर डिसीज जो अल्कोहोलमुळे होतो, आणि लिव्हर डिसीज जे अल्कोहोलमुळे होत नाही, ते नॅचरल प्रोग्रेशन ऑफ डिसीज म्हणतो आपण, ते होतं. अल्कोहोलिक डिसीजमध्ये बऱ्याच वेळा आमच्यासारखी जी हॉस्पिटल आहे त्याच्यामध्ये फंडिंग रेज करणं खूप डिफिकल्ट असतं, कारण की कुठल्याही चॅरिटेबल संस्था किंवा कोणीही ह्या फंडिंग करण्यासाठी तयार होत नाही, कारण की हा आजार स्वतःच्या सेल्फ इन्फेक्शन किंवा सेल्फ याच्यामुळे होतो. बट अदर जे आपण म्हणतो त्याच्यामध्ये बऱ्याच प्रमाणात चॅरिटेबल इन्स्टिट्यूट किंवा समाजातील काही जी डोनेटर्स आहेत ते पुढे येऊन ह्या आजारामध्ये मदत करण्यासाठी तयार होतात. बरेच असे लहान मुलांचे लिव्हर रिलेटेड डिसीज आहेत किंवा मोठ्यांचे आहेत, त्याच्यामध्ये आम्ही स्वतःहून बाहेर जाऊन चॅरिटेबल फंडिंग रेज करून ती ट्रीटमेंट केलेली आहे. तुम्ही जसं म्हणता ह्याच्यामध्ये ओव्हरऑल कॉस्टिंग खूप जास्त प्रमाणामध्ये असते, कारण की याच्यामध्ये लागणारी जी औषधंच असतात त्याच्यामध्ये इन्फेक्शन म्हणा किंवा अल्बिनिक असं ड्रग आहे जे जास्त प्रमाणात लागतं, त्याच्यामुळे कॉस्ट जास्त असते. त्यामध्ये जितकी मदत करता येण्यासारखं आहे त्याच्यामध्ये आपण करतो, आणि आम्ही जे म्हटलं चॅरिटेबल सोर्सेस आहेत आणि त्याच्यामधून आपण त्यांना मदत करण्याचा प्रयत्न करतो.
That is coming in, which is called as metabolic dysfunction associated steatotic liver disease. Now, what was called as NASH or non-alcoholic liver disease has now been renamed, and it is more of a gamut of multiple issues that a liver patient will have. Now, predominantly, any patient who is having a liver disease because of alcohol will have obviously symptoms because of alcohol withdrawal also, which these patients with fatty liver disease would not have. Fatty liver disease patients are diagnosed pretty late because it takes time for that liver to become eventually cirrhotic. It doesn't happen over a period of time. It takes time, at least 10 to 15 years. And in this particular time frame, they may not have any symptom. So that is why the idea of doing health checks comes in, where we can diagnose these patients early, where we see their liver functions are a bit deranged, or if they have a fat in the liver, then we evaluate them further using a fibro scan. These patients do not have any symptoms for that matter. It is only when the patient's liver becomes cirrhotic and there are complications because of loss of liver, that is the point of time we pick them up, and that is eventually late. So, to answer the question simply, there is no such symptom that a fatty liver patient would have, apart from mild discomfort. If at all the patient has 20% only will complain about that. So, doing a regular health check to pick it up early, I think amongst all of us, 4 of 10 will have a fatty liver disease, and it's a fact. That's what the data tells us, and it's a fact. When we look at health checks, that's what we come to know, and hence it is very important for a regular health check. Now, when these patients eventually have symptoms, is when the liver is already cirrhotic. Means that liver kharab zala hai, 80% covered, and then they have complications like पेट में पानी भरना, cycles that we have, or affection of the kidney, they become jaundice, that is obvious, and that is the point of time when they come for help. The idea is to catch them more early and not that late.
The question is, which one is bad? Which is moderate?
Obviously, both are bad if you look at overall, but mortality-wise, I think alcohol is more worse. It's because it affects the other organs also. Obviously, fatty livers also affects the heart. But in terms of mortality, how bad we are, early on deaths would be more of alcohol-related liver disease, and less likely, not definitely not at all, but less likely as fatty liver disease.
Does it mean that every fatty liver will eventually
Absolutely not. It's only a cohort of patients who have fatty liver disease will eventually develop inflammation. Not all with inflammation will develop cirrhosis. So if you look at the natural history of fatty liver disease, it takes at least 10 to 15 years for them to eventually develop cirrhosis, and it is not everybody. It is there are certain genetic traits that push a liver, or probably something in the genes, probably something in the diet that pushes, or only a few set of patients into inflammation and eventually into fibrosis and cirrhosis. So when you look at, if you look at like 10 patients with fatty liver disease, only like 3 or 4 of them will have inflammation. Out of those 3 or 4, if you make them 100, only around 10 to 15% will eventually develop cirrhosis of liver. So 10 patients may say maybe just 0.5 to 1 would eventually have cirrhosis of liver, not all. And hence the idea is to correct them as early as possible before they develop cirrhosis.
any person who had had jaundice in childhood or in the youth days, is that person's liver under danger to develop this?
So there are certain liver diseases in childhood that can affect the liver. For example, Wilson's disease, hemochromatosis, or you have biliary which is the most common reason why liver transplant happens in a child. But most of us probably would have had jaundice, and that is because hepatitis A and E virus, which is self-limiting illness. So not all patients who have prior history of jaundice would have a liver which is bad as time would pass. It is only those who have either genetic problems or something like a inborn errors of metabolism or problems with the anatomy of the biliary tree, those only would end up having the transplant. And yes, as I told when I spoke, there are certain group of patients even with hepatitis A and E who can eventually have acute liver failure, and these are the patients who we need to identify when they are admitted in the ICU. Not everybody. I mean, if 1,000 patients, only one may have it, if at all. So this is the group of patients which we need to identify early because they require liver ICU care and they require a transplant backup, but not all.
Again, it depends on how severe they came inside the ICU. Suppose somebody who comes with only liver problem came with some amount of blood vomiting and all, they get treated very fast. We do the endoscopy, we control the bleeding, they go out of the ICU in a day or two. But suppose somebody who has come to the ICU with a failing kidneys or brain or some other organs, they obviously requires more time. That means that the sickness, the initial stage of the sickness is much higher. So they require a little longer care than inside ICU.
हर organ body में affect होता है. Every organ, it may not present itself, it may present itself, but diabetes is a systemic illness. तर असं नाही की फक्त डायबिटीजमुळे फक्त लिव्हर खराब होतं. You understand? But there are some organs which will get more affected than the other organs. And diabetes is presently, I think, it's a lifelong illness. It's just ongoing. It's just a question of how well you control it during the entire stage of the illness. So, major affection that I think so far we've seen is with the heart, but liver also does get affected, and that is what is becoming more and more prominent or evident. Now, you have to look at it just as Dr. Amani said, it's a cohort of symptoms. So when you look at it, diabetes affects the metabolism, and the metabolism will also affect the liver. What has happened nowadays is we have poor food habits, we have sedentary lifestyles, lack of exercise, and easy high calorie food on the click of a button on the phone has become available to just about everybody. So this habit or the group of habits is what is affecting everybody, and each one's, some organ will get affected in that process. Some people's heart are getting affected, some people's liver is getting affected. And because of the awareness, the liver is also getting picked up earlier and earlier, so we are seeing that fatty liver becoming that common. And as Dr. Samay said, amongst this whole group of fatty liver, some percentage will go into inflammation, some percentage will go into fibrosis, some will go into cirrhosis, and some major part of those cirrhotic patients will end up in our liver ICUs or in hospitals with some sort of problem following their cirrhosis.
What I'm saying that you can trust Apollo Hospital. So this is the best possible what we can offer, and you can trust the patient's life, because particularly the patients who are fighting for life and death in the context of acute liver failure.
And Apollo Hospital, Navi Mumbai, has a quaternary care center for the in terms of ICU care, intensive care unit care. It is important to send patients early. Like suppose somebody who has developed some liver dysfunction, before other organs get affected, it is important to send them early so that they get recovered far faster. And as we have said multiple times repeatedly, liver disease affects multiple organs simultaneously, and more the organs gets involved, the larger number of the problem happens. So it is better to send come the patient comes with a less sick state where they get better.
So early referral is very important. What he's trying to say. Once you know that the liver is not working, so best way to just go to the hospital which can offer you most of the services.
And we provide a kind of umbrella care to all kinds of patients. So somebody with a liver disease has some heart problem, we always cater to those things. Somebody has a kidney problem, we are equipped to handle those kinds of things. So that is why it is important to have this kind of integrated approach.
So तुम्ही काय काय फॅसिलिटी देणार आहात आता जे आपण प्लेस आहात काय फॅसिलिटी
आईसीयू में सारी टाइप का फैसिलिटीज है, लाइक किसी को ब्रीदिंग सपोर्ट लगता है, किसी को किडनी सपोर्ट लगता है, किसी को ऑक्सीजन सपोर्ट लगता है, ऑल काइंड्स ऑफ मेडिकल फैसिलिटीज आईसीयू में हम लोग दे सकते हैं.
So अजून एक CRRT.
In addition to that, basically, जे लिव्हर फेल्युअरचे पेशंट असतात ते विल रिक्वायर मॉनिटरिंग, मतलब एव्हरी 24/7 दर सेकंदाला दर मिनिटाला वी नो हाऊ मच इज द बीपी, हाऊ मच इज द पल्स, विच इज नॉट पॉसिबल इन अदर एरियाज कंटिन्युअसली टू मॉनिटर द पेशंट. फर्स्ट थिंग. सेकंड, एक वेगळ्या प्रकारचं डायलिसिस असते, ज्याला आम्ही CRRT म्हणतो. नॉर्मल पेशंट म्हणजे डायलिसिस लागतं आणि लिव्हरच्या पेशंट म्हणजे डायलिसिस लागतं, थोडा फरक आहे त्याच्यात. दॅट वी कॅन ऑफर टू द. सेकंड थिंग, दिस पेशंट्स रिक्वायर लॉट ऑफ ब्लड, FFP, व्हाईट ब्लड, क्रायो, एकाच ग्रुपमध्ये आहे. थर्ड फ्लोरला ICU, सेकंड फ्लोरला ब्लड बँक आहे. आणि इन ॲडिशन टू द डॉक्टर्स, सपोर्टिव्ह स्टाफ जो असतो त्याला आम्ही न्यूट्रिशनिस्ट म्हणतो, किंवा बाकी सोशल वर्कर जे असतात, ते ऑल 24/7 दे आर विथ द पेशंट, अराउंड द पेशंट. सो दॅट विल हेल्प इन बेटर आउटकम ऑफ द पेशंट्स. सो दीज आर द little difficult, not out of the way facilities which we are providing to the liver patients in addition to what normally we do.
बरेच वेळेचे acute liver failure पेशंट असतात त्यांच्याकडे इन्फ्लमेशन खूप असतं, असे घटक बॉडीमध्ये अशी सूज खूप येते. त्या सूजला काढण्यासाठी आपण प्लाझ्मा एक्सचेंज करतो, पूर्ण प्लाझ्मा काढून नवीन प्लाझ्मा किंवा अल्बुमिन टाकतो बॉडीमध्ये. ही पण फॅसिलिटी अवेलेबल आहे की रॅटॉल पॉइजनिंग.
सो मोस्ट ऑफ द रैटल पॉइजनिंग जहाँ पे लीवर कम्प्लीटली खराब होता है, तो उसमें बॉडी में काफ़ी ज़्यादा इन्फ्लेमेशंस मतलब सूजन होता है. वो इन्फ्लेमेशंस के लिए बाकी सारे ऑर्गन्स प्रॉब्लम है. तो हम लोग क्या करते हैं, जो इन्फ्लेमेटर जो दूषित मटेरियल्स है वो ब्लड में रहते हैं. वो ब्लड प्यूरिफिकेशन डिवाइस रहता है जिसको प्लाज्मा एक्सचेंज बोलते हैं. ब्लड प्यूरिफिकेशन डिवाइस से इंटर ब्लड हम लोग जो प्लाज्मा है उसको एक्सचेंज करते हैं एंड नया जो न्यू प्लाज्मा है वो हम लोग इंस्टिल करते हैं, सो दैट इसके साथ रिकवरी अच्छा होता है। तो ये सारी फैसिलिटीज़ अपने हॉस्पिटल में है। एंड मोस्ट ऑफ द सेंटर्स में जो प्लाज्मा एक्सचेंज डिवाइसेस है, sick liver patients they cannot tolerate. So the technique that we use over here एक स्लो प्रोसेस है, इसमें एक्सचेंज रेट काफ़ी अच्छा होता है एंड इन दैट केस पेशेंट टॉलरेशन अच्छा होता है एंड देन एक बार पेशेंट टॉलरेशन अच्छा होता है तो इन दैट केस द पेशेंट्स गेट्स बेटर आल्सो।
सर ट्रांसप्लांट की बात की गई है तो मिनिमम कम से कम कितना खर्चा आ जाएगा आपने?
सो यहाँ अपोलो हॉस्पिटल में राउंड अबाउट एक 15 to 17-18 लाख तक खर्चा होता है। जैसे डॉक्टर शिंगोटे ने बताया कि जिनको मदद लगता है उनको हम अपने फाउंडेशन से या फिर चैरिटेबल ऑर्गेनाइजेशन से ज़्यादा मदद करने की कोशिश करते हैं। ऑब्वियसली महाराष्ट्र में सीएम फंड से भी कुछ मदद होता है, पीएम फंड से भी मदद होता है। सो ऑल दिस मिला के वी कैन एटलीस्ट एक 10-12 लाख तक पेशेंट ने अगर कंट्रीब्यूट किया तो बाकी का हम लोग एडिशनल कंट्रीब्यूशन हम
पेशेंट कितने दिनों में ट्रांसप्लांट के बाद ठीक हो जाते हैं, उनको कितने दिन से काम करते हैं?
सो ऑलमोस्ट 95% ऑफ आवर पेशेंट्स 2 हफ्ते में घर चले जाते हैं। ठीक है, जो बहुत सिक है उनको रिकवरी में भी ज़्यादा टाइम लग सकता है, बट 95% तक लोग 2 हफ्ते में घर चले जाते हैं।
So just adding for the sake of
ये किया जाता है
तो
कितना लीवर खराब हो गया और उसके बाद में ऑपरेशन की
तो जैसे डॉक्टर अमन ने कुछ देर पहले बताया कि जब तक 70 to 80% अपना लिवर डैमेज होता है तब तक किसी को कुछ पता भी नहीं लगता। जैसे मैंने बताया कि 30% लोग अपने में से भी कुछ ना कुछ लिवर अफेक्शन रहेगा, लेकिन सब अच्छे खासे रहे। तो जब तक 70-80% डैमेज नहीं होता है, कुछ सिम्टम्स नहीं आते, तो एक बार वो शुरू हो गया तो फिर उनको एक इंडिकेशन बनता है कि वो ट्रांसप्लांट, क्योंकि उसके बाद लिवर अपने आप से रिपेयर नहीं हो सकता। तो ऐसे पेशेंट्स को ट्रांसप्लांट की जरूरत पड़ती है।
सिम्टम्स क्या होते हैं? बचाव के लिए क्या करना चाहिए? बचाव
एक मिनट, सिम्टम्स पहले बताया। तो सिम्टम्स एक तो जॉन्डिस रहेगा, पेट में पानी, पैरों में सूजन, एल्ब्यूमिन लेवल लो होगा, ब्लड क्लॉटिंग में प्रॉब्लम्स रहेगा, या तो ब्लीडिंग यहाँ वहाँ से होगा, खून की उल्टी हो सकती है, या तो खून मोशन में पास हो सकता है। और गफलत जो बोलते हैं, ब्रेन में जो सूजन आता है उसकी वजह से पेशेंट कंफ्यूज रहेगा या कुछ अजीब सा बोलने लगेगा, अजीब हरकतें करने लगता है। किडनी अफेक्शन कभी कभी लिवर की वजह से होता है, जिसमें क्रिएटिनिन बढ़ने लगता है या फिर यूरिन आउटपुट ड्रॉप होता है। ये सब सीरियस अफेक्शन जो जो दिखाता है कि लिवर अभी बिल्कुल काम करना बंद हो रहा है, इसलिए बाकी ऑर्गन भी अफेक्ट हो रहे हैं। तो ये सब ग्रुप जो है, इनको ऑप्टिमाइज करने के लिए हमारे लिवर आईसीयू में रहना जरूरी है, ट्रीट करना जरूरी है, और एक बार वो स्टेबलाइज हो गए तो फिर ट्रांसप्लांट की तरफ लेके जाते हैं ऐसे पेशेंट्स। आप कुछ और पूछ रहे हैं?
बचाव के लिए क्या करना चाहिए? अगर अर्जेंट में नहीं समझ में आ रहा है तो उस तरह के पेशेंट को क्या किस तरह से आप सजेशन देंगे कि आप जल्द से जल्द?
बचाव के लिए जैसे पहले बताया कि जो कॉज है ये लिवर डिजीज का, वो पहले बंद करना है। अगर अल्कोहल है तो अल्कोहल बंद करना है, अगर फैटी लिवर की वजह से या डायबिटीज की वजह से तो डायबिटीज कंट्रोल में लाना है, सेडेंटरी लाइफस्टाइल अवॉइड करना है, थोड़ा बहुत एक्सरसाइज करना है, वेट घटाएंगे और शुगर कंट्रोल में लाएंगे तो ये एक सिंड्रोम जो है वो थोड़ा बहुत कंट्रोल में लेके आ सकते हैं। लेकिन आपको ये याद रखना है कि कोई भी बीमारी, लिवर बहुत ही एक बड़ा ऑर्गन है और उसको अफेक्ट करने के लिए भी बहुत कुछ लगता है। तो हेपेटाइटिस जो बोलते हैं वो लिवर की सूजन है, किसी तरह का अफेक्शन जब लिवर का होता है तो उसको हेपेटाइटिस बोलते हैं। इसके अलग अलग कारण है, मतलब वायरस में अगर रह गए तो हेपेटाइटिस वायरस 5 अलग अलग टाइप के रहते हैं, वो अफेक्ट कर सकता है। अल्कोहल अफेक्ट कर सकता है, अल्कोहलिक हेपेटाइटिस जो बोलते हैं तो अल्कोहल की वजह से लिवर पे सूजन आता है। स्टेटोहेपेटाइटिस मतलब फैटी लिवर की वजह से लिवर पे सूजन आता है। तो ये सब कारण है अलग अलग जिसकी वजह से लिवर अफेक्शन होता है, और ये जब एक एक करके अवॉइड करेंगे तो फिर आप लिवर को बचा सकते हैं।
So I'll just add basically, symptoms आने तक आप रुको मत। Now the question is that so after symptoms है तो आप डॉक्टर के पास तो जाने वाले हो, but before that whether we can do something. So what you have seen कि हर एक हॉस्पिटल में एज 40 होता है, so you just do your routine health checkup और किसी sensible doctor को this is first thing. If you are diabetic, you control the sugar. If you feel you are overweight, you control the weight and don't do any non-allopathic medication. I'm not able to say, but कौन सा भी मेडिकेशन आप लेते हो, whether it is herbs or ayurvedic and all that, so you consult your doctor under medical supervision only you take, because sometimes we see कि कुछ मेडिकल ऐसे है, मेडिसिन ऐसे है जिसकी वजह से भी लिवर खराब होता है, हेवी मेटल्स वगैरह। So whatever you do, you consult your doctor and after 40 or 45 You just do your routine health checkup and consult your private physician or person.